Welcome to the deep dive. Today, we're tackling a really interesting area, laparoscopic and robotic techniques in aortic surgery.
That's right. We're going deep into these sort of minimally invasive alternatives to the big open operations.
Exactly, for things like abdominal aortic aneurysms, AAAs, and aortoiliac occlusive disease, AIOD.
And it's important to say, while those catheter-based endovascular procedures are super common now,
Yeah, they really are.
these laparoscopic methods still have a crucial role for certain patients where maybe endovascular isn't the best fit.
Right. So to get our heads around this, we're digging into Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. Pretty much the authority.
Definitely the go-to text.
Our mission, then, is to really unpack these techniques, laparoscopic, robotics, see what they offer, their downsides, and just get a solid picture of where things stand right now based on Rutherford's.
Sounds like a plan.
Okay, let's dive in. First up, total laparoscopic aortic surgery, TLAS. What are we actually talking about here?
So TLAS, it means doing the whole aortic repair using just small keyhole incisions, with special long instruments and a camera.
All through tiny holes, basically.
Pretty much. And the textbook breaks it down into 4 main ways surgeons can get access. 4 approaches.
4 ways.
Yeah.
Okay. Let's take the first one. The retrocholic prerenal transperitoneal approach. Wow, that's a bit technical.
It is a bit of a mouthful.
Mhm.
So this one, they often use it for blockages lower down in the iliacs, patients on their back.
Okay.
Maybe a little pillow under the left side, table tilted slightly right. Then they place the ports, the little entry points, in specific spots.
Relative to the belly button and stuff.
Yeah, exactly.
Okay.
Like xiphoid, umbilicus, iliac fossa. Then the actual surgery involves going in from the left side,
Right.
moving the left colon aside, getting to the aorta, which is in front of the kidneys in this approach. The key thing is going this route behind the colon, in front of the kidney. It gives you a pretty big working space.
Oh, I see. Because the intestines sort of fall away.
Exactly. Gravity helps, the tilt helps, it creates this natural opening.
Okay, that makes sense. More room to work. What's the second approach?
Second one is the retrocholic, retrorenal, transperitoneal approach.
Retrorenal. So behind the kidney this time.
Right. This one's maybe preferred for, say, thinner patients or if someone's had surgery on their left kidney or colon before.
Ah, so previous surgery matters.
Definitely. Or if you need to clamp the aorta higher up, above the renal arteries, or even for treating in AAA itself.
Okay.
The technique here involves lifting the left colon and the left kidney up. Sometimes they even have to divide a small vein, the renoazygos lumbar vein, to get the right exposure.
So a bit more involved, perhaps, for getting higher up the aorta.
Yeah, potentially. Useful for those specific, maybe more complex situations.
Got it. And the third one, you mentioned a combined approach.
Yes, the combined transperitoneal and retroperitoneal. The really neat trick here is creating what they call a peritoneal apron.
A peritoneal apron. What's that?
Imagine making like a little pouch out of the peritoneum, the lining of the abdomen,
Okay.
and you use that pouch to just hold the intestines back, keep them out of the surgical field.
Ah, like a built-in retractor?
Sort of. It's pretty clever. Keeps things tidy without needing a big incision. Rutherford's credits Dion for the idea, and then Kaja simplified it later on.
Ingenious. Okay, what about the fourth way?
The last one is the retroperitoneal approach. This involves a small cut, more like a mini laparotomy.
So not just keyholes.
Not entirely. You make a small cut, then dissect behind the main abdominal cavity in that retroperitoneal space. But the book notes it's not used as much.
Why is that?
Mainly because the working space is just smaller back there. And also, the CO2 gas they use to inflate the belly for laparoscopy, it can leak into that space and make it even tighter.
Ah, so it can become quite cramped.
Yeah, more confined. So less popular overall.
Okay. So once the surgeon's chosen their path, how do they actually, stop the blood flow and sew in the graft with these long tools?
Well, they use specialized laparoscopic clamps. They go in through the ports, grab the aorta, and temporarily stop the blood flow.
Right, the clamping.
Then the sewing part, the anastomosis, usually done with long, strong sutures, polypropylene, often with those little pledgets we mentioned.
The reinforcement patches.
Exactly, just to buttress the suture line. Or sometimes they use automatic staplers. The book mentions the Endopath ETS Flex 45.
Staplers for the aorta.
Yeah, but the aortic wall needs to be, relatively healthy, not too calcified or hardened for the staples to work well. Can save time, though.
Makes sense.
Yeah.
And connecting the graft down to the legs. the femoral arteries.
Right. So the graft, often Y-shaped, gets carefully tunneled down towards the groin using another laparoscopic instrument, maybe a clamp.
Okay.
And there's an interesting detail for that first approach, the retrocholic prerenal one.
Yeah.
Sometimes the tied-off end of the graft's left leg is just left inside the abdomen after it's sewn to the aorta.
Really? Just left there?
Yeah, apparently. Then, once everything's connected, they lower the gas pressure inside the abdomen
Why lower the pressure?
to check carefully for any bleeding. Small veins especially might have been squashed by the higher pressure, so lowering it lets you see if they start oozing. Then they put the colon back over the graft.
Fascinating detail about leaving the graft in. Okay, let's shift. Hand-assisted laparoscopic surgery, HALS. How's this different from pure TLAS?
HALS is, well, it's a hybrid. You use a special port, a bigger one, that allows the surgeon to stick their non-dominant hand right into the abdomen.
While keeping the gas in.
Exactly, while maintaining the pneumoperitoneum.
So you get the laparoscopic view and the sense of touch.
Precisely. Patients usually flat on their back, a small cut, maybe 7/8 centimeter, often midline for that hand port.
Okay.
And the surgeon's hand inside is really useful. You can gently move bowel, feel the tissues, help with the dissection. That tactile feedback is a big plus.
I bet. That must make a huge difference in feel.
It really can. And often the book says the main connection, the proximal anastomosis to the aorta, is done under direct vision through that hand port incision, using regular instruments.
Ah, so sewing directly, not just with long tools for that bit.
Often, yeah. So HALS helps get around some of the toughest parts of pure laparoscopy, especially the sewing.
But it's a bigger incision than TLAS, right?
That's the trade-off. It's
Huh.
more invasive than TLAS because of that hand port incision. So it's, balancing the benefit of touch against minimizing the incision size.
Right, always a balance. Okay, now on to the really high-tech stuff. Totally robotic aortic surgery and robot-assisted procedures. What's the big draw with robots here?
Dexterity. That's the headline. Robotic instruments have like 5 to 7 degrees of freedom,
Yeah.
way more flexible than standard straight stick lap instruments.
So they can bend and rotate like a wrist.
Exactly, much more like a human wrist. Combine that with amazing high-def 3D vision inside the body.
Wow.
And it potentially makes complex stuff like suturing deep down, easier to learn and execute really precisely, more intuitive.
More natural movements for the surgeon, then. Tell us about the Da Vinci system. That's the main one, right?
Yeah, that's the primary system discussed. It's got 3 main bits. The patient side cart with the robotic arms,
Okay.
an instrument tower for the video and instruments, and then the surgeon's console. That's where the surgeon actually sits, maybe across the room.
They're not right at the patient.
Nope, they're looking into the console, controlling the robotic arms remotely. But the key is their hand movements at the console translate very directly, very intuitively to the robot's movements. It mimics open surgery feel, but through tiny holes.
That sounds like it could really help bridge the gap from open surgery skills.
Yeah.
How's the patient set up for a fully robotic case?
Positioning is, well, it's similar to TLAS, but maybe more extreme. Often a steeper table tilt, maybe 45 degrees. Sometimes special pillows like the pelvic tilt pillow.
To get gravity to help even more.
Exactly. Optimize the view and access. And the trocar placement, the ports for the robot arms, is super critical
Why's that?
because the arms need space to move without clashing. They're usually put along the left side, maybe axillary lines, spaced out just right. Placement might even differ slightly for aneurysm versus occlusive disease.
Interesting.
And the robot itself is usually docked, connected to the patient ports from the left side of the table. It's all about the geometry.
Makes sense. What tools do the robots use? Like scissors and...
Yeah, common ones are monopolar scissors for cutting, bipolar forceps for grabbing and sealing vessels, and they use different angled cameras, endoscopes, usually 0 and 30 degrees, to look around corners, essentially.
Okay. And can they do those same approaches we talked about before?
Yep. Both the retrocholic prerenal and the retrorenal approaches can be done robotically.
So where does the robot really excel in these aortic procedures?
It really shines in complex dissections, like working high up near the kidney arteries, the suprarenal aorta, or down low where the aorta splits into the iliacs, very delicate areas.
Because of the precision.
Precision and the view. Makes placing clamps accurately much easier, too. For AAAs, they can use robotic tools to clip off those little lumbar arteries feeding the sac.
Right, to stop back bleeding.
Exactly. And they might use a special fenestrated grasper one with holes to handle the aneurysm sac gently. For sewing, they often use Gore-Tex suture, and there's a specific running stitch technique using a pledget to anchor it.
Sounds incredibly precise. Any downsides to robotic suturing?
The big one is a lack of haptic feedback. Touch.
You can't feel the tissues through the robot.
Not directly, no. Unlike open or even hand-assisted, surgeons have to compensate by really relying on that amazing visual feedback, learning to feel through the instruments visually. It's a different skill.
A trade-off there. The book also mentions robot-assisted surgery. How's that different from totally robotic?
Robot-assisted means the robot isn't doing the whole thing. It's used for specific, usually the most demanding parts.
Like the sewing.
Exactly. Often the anastomosis. Maybe the initial exposure is done laparoscopically, then a small incision mini laparotomy is made to put the graft in, and then the robot is brought in just for the precision sewing.
So, using the robot strategically for its strengths.
Precisely. Leverage its advantages for the trickiest bits, maybe save some clamp time on the aorta.
Okay, that makes sense. Now, shifting gears again, what does the actual published research say about how these techniques perform? The outcomes?
So Rutherford's reviewed studies from 1995 to 2020. They found 24 on total laparoscopy, TLAS, 14 on hand-assisted or mini-lap-assisted, and 10 on robot-assisted procedures.
A decent number of studies, then.
Yeah, enough to start seeing some patterns, though, with caveats.
Okay, let's get into those findings. What about operating time? How long do these take?
Well, it varied a lot. Operative times were all over the place, really. Hand-assisted often came out shortest on average,
Oh, interesting.
but with a really wide range. Some were quick, some took ages. For TLAS and occlusive disease, the range reported was like 199 minutes up to nearly 400 minutes, a big difference.
Wow, that's huge variability. What about clamp time? How long is blood flow stopped?
Similar story, a significant variation. Shortest average was HALS for occlusive disease, maybe around 28 minutes in some reports. Longest was TLAS for aneurysm repair, averaging maybe 146 minutes, but again, depends hugely on the center, the surgeon, the patient.
Understood.
Okay.
What about converting? Having to switch from minimally invasive to a full open operation midstream, that must happen sometimes.
It does, and it's a key thing to track. Conversion rates seemed higher for TLAS, around 8 or 9% maybe,
Okay.
compared to HALS or mini-lap assisted, which were lower, maybe 2 to 4%.
And why would they need to convert?
Common reasons were finding the aorta was really badly calcified, rock hard basically, or unexpected significant bleeding that was hard to control laparoscopically, or just the procedure taking way too long, raising safety concerns.
Safety first. Makes sense. You bail out if needed. What about the really serious outcomes, like mortality?
Overall, 30-day mortality across the board was reported around 1.8%. Importantly, for AAA repair, there wasn't a statistically significant difference found between TLAS and HALS mortality.
So similar risk of death early on for those two, at least in the studies looked at.
Seems that way, yeah. The numbers were roughly 3.4% for TLAS and 1.9% for HALS in AAA repair, but statistically not different enough to say one was definitively riskier based on that data.
Okay. And other complications?
Yeah.
Morbidity?
Most frequent things reported were bleeding, needing transfusions, and acute kidney problems.
Kidney issues, okay.
Yeah. Others included leg ischemia, not enough blood flow ischemic colitis affecting the bowel, graft clotting off, heart attacks. The book notes these seemed maybe a bit more common after TLAS for aneurysm, but they also add a big caution. How complications get reported isn't always consistent between studies, so comparing is tricky.
Right, comparing apples and oranges sometimes. What about hospital stay? How long are people in for?
Again, quite a range. Median stays reported were anywhere from 4 days up to 13 days across all the techniques. Lots of factors influence that.
Patient health, complexity, hospital protocols.
Yeah.
Okay. Did the book mention any specific studies comparing, say, TLAS versus robotic?
Yes, there was one comparative study highlighted. It found that the actual sewing time, the anastomosis time, was shorter with the robot.
Ah, so the robot was faster for the tricky bit.
For that specific part, yes. But, and this is the catch, the total procedure time was actually longer with the robot.
Longer overall. Why?
Because of the setup time. Getting the robot positioned, docked, ready to go, that adds time up front. So faster sewing, but longer overall case time in that study.
An interesting trade-off. Were there any complications specifically linked more to the laparoscopic approaches in general?
Yeah, a few were mentioned. Bleeding from those small lumbar veins in the back, they can retract and be hard to catch laparoscopically. Also, retroperitoneal hematoma bleeding into that space behind the abdomen, maybe from the dissection. Ureteral injuries, though rare. and early graft thrombosis, the graft clotting off soon after surgery.
Important risks to be aware of.
Yeah.
Okay, let's pull back and look at the textbook's overall conclusions. Why were vascular surgeons a bit slow to jump on the laparoscopy bandwagon initially?
Rutherford suggests two main things. One, the rise of endovascular treatments, especially stenting for iliac blockages. That took away some potential candidates for a laparoscopic bypass.
So the need decreased a bit.
In certain areas, yeah. And two, it's just really technically difficult. Laparoscopic aortic surgery has a steep learning curve, and not many surgeons initially had that very specialized training.
Right, tough skills to master. But the idea of less invasive aortic surgery didn't go away.
No, absolutely not. The goal was always trying to get those great open surgery results, but with smaller cuts, less pain, faster recovery maybe.
Makes sense.
And the book traces that evolution, from the early hand-assisted attempts to the fully laparoscopic stuff, crediting pioneers like Dion and Kojia for that left retrocholic approach.
And what's the current view on TLAS, according to the text?
The take is that, yes, TLAS can be done safely and well for complex cases, but it really needs specialized centers, experienced teams. The training requirement is huge, especially for mastering that lap aortic anastomosis.
Right, the sewing is key.
Totally. And they suggest HALS using the hand assist can be a good bridge, maybe lower the risk while surgeons are climbing that learning curve.
So experience and careful patient selection are paramount. How does it compare overall to open or endo in the textbook summary?
Well, the big caveat they stress is the lack of large randomized controlled trials. We don't have that definitive head-to-head comparison.
Still waiting for the gold standard evidence.
Pretty much. But based on existing studies, there's a suggestion maybe of fewer lung complications with laparoscopy compared to open surgery. Probably the smaller incisions help breathing. But on the flip side, operating times and clamp times tend to be longer than open. And that higher conversion rate for TLAS in aneurysm disease is noted again.
Longer times, higher chance of needing to switch, and blood loss.
Interestingly, average blood loss seems pretty comparable to open surgery in many studies, although they mention extremes can happen, especially with really calcified aortas.
Okay.
There was also that small trial suggesting HALS might be less invasive for younger sexually active men, not suitable for EVAR endovascular repair.
So specific patient groups might benefit more.
Mm.
What about that RICO study you mentioned earlier? What was the takeaway there?
Right, the RICO study used propensity score matching to try and compare TLAS and open surgery more fairly. Their finding was a bit surprising.
Oh, so?
They suggested TLAS might actually carry a higher risk of adverse events, even with experienced teams. It kind of went against the grain of some other observational data.
Really?
Yeah, they speculated their statistical method might have controlled for biases better. It's a good reminder that we need really rigorous research to sort this out.
Absolutely. Need that solid evidence. Okay, circling back to the robot, how does it fit into overcoming those laparoscopic challenges?
As we touched on, it directly addresses things like limited dexterity and 2D vision, that robotic wrist, the 3D view. It allows surgeons to do more complex maneuvers, finer dissections, maybe more easily than standard laparoscopy.
Making the hard parts potentially easier.
Potentially, yes. The book suggests it might offer durable solutions for things like iliac aneurysms without some risks of endo leaks or open incision hernias.
Okay. What about robotic conversion rates and limitations?
Conversion rates reported are, again, variable. Maybe 3% for occlusive disease up to maybe 13% for aneurysms. Reasons include technical robot issues or bleeding, like from those lumbar arteries again.
So still not zero risk of conversion.
Definitely not. And the book highlights the robot helps beyond just sewing, improves visualization, makes dissection easier. But the big hurdles remain. Cost.
Huge cost, right?
Massive cost, yeah. And setup time in the OR. Although, interestingly, the learning curve specifically for robotic anastomosis seems potentially shorter than for pure laparoscopic sewing.
Faster to learn the sewing part, maybe.
That's the suggestion. They even mention using robots to fix type 2 endoleaks after EVAR sometimes.
Wow, okay. So overall then, how do lap and robotic recovery times stack up against open and endo in the textbook's view?
The bottom line is hospital stays after lap or robotic aortic surgery tend to be similar to open surgery stays.
So similar to open, not shorter.
Generally similar, and usually longer than after endovascular repair. Plus, lap and robotic almost always need general anesthesia.
Whereas endo can sometimes avoid that.
Right. Endo can often be done with regional or even local. So that difference in overall invasiveness and recovery probably explains why these advanced laparoscopic and robotic techniques are still mostly concentrated in specialized centers.
Okay, so despite smaller scars, the overall physiological impact and recovery might not be drastically less than open, and certainly more than endo. What's the final word from Rutherford's on laparoscopic aortic surgery?
The conclusion is it can be safe and effective with decent outcomes, but patient selection has to be meticulous, surgeons need deep experience, and they must be ready and willing to convert to open if things get difficult.
Liberal conversion criteria.
Exactly. But its ultimate place, its long-term value compared to other options, that still needs defining. They strongly emphasize the need for those large, multi-center randomized trials to really prove the benefit for specific patients who aren't candidates for endovascular repair.
More robust evidence is the key message.
Absolutely.
Well, that was incredibly thorough, a real deep dive into laparoscopic and robotic aortic surgery. It seems the takeaway is these are valuable, less invasive tools for the right patient in the right hands. But they come with significant technical challenges, potentially longer procedures than open, and we're still waiting for definitive proof of superiority in many situations. And endovascular is often still the first minimally invasive choice.
That sums it up well. There are important options when endo isn't feasible, but not necessarily a replacement across the board.
Which leads to a really interesting question for the future, doesn't it?
It does. Where is this all heading? With technology moving so fast in both endovascular and minimally invasive surgery, what's aortic repair going to look like in, say, 10 years?
Yeah, will robotics overcome its current hurdles, cost, setup time, haptics enough to become more mainstream for aortic work?
Or will endovascular tech keep expanding its reach? It's this constant interplay between reducing invasiveness, ensuring great long-term results, and leveraging new technology. A fascinating space to watch.
Definitely food for thought. We'd love to hear what you think or any of the questions that came up during this deep dive. Thanks so much for joining us.